Welcome to Healthcare Quality and Risk Matters, the show where we dive into the topics that matter most in healthcare quality and risk management. Wondering about patient safety, quality improvement, or risk mitigation, but weren't sure who to ask or were afraid to ask? Well, you're in the right place. We create a safe and judgment-free space to explore these critical topics together that will leave you informed and inspired to make a positive impact on healthcare and patient outcomes. So let's learn and grow together because healthcare matters.
Well, hello, everybody, and welcome to the February edition of Healthcare Quality and Risk Risk Matters. Yes, this is a live show. My name is Gary Bierc. I am the CEO of Aperitisoft Healthcare, and I am joined by my two esteemed colleagues, Rob Santamoor, who is our Chief Operating Officer, and Timothy L. Brown, the good doctor, who is our SVP of what are we calling it these days? Customer success.
Customer success.
Customer
Yes,
success. Rob is our resident nurse, and he also is our healthcare quality expert. Well over 15, 20 years of experience, right, Rob, in that area?
Feels like about 40, but yeah.
It feels like 40, yeah. And then Dr. Brown is our healthcare administration expert and has really interesting insights. And I'm your resident risk manager. I've got over 40 years experience in risk management. So I'm always kind of pushing against the healthcare world all the time. So we're glad that you're with us today. And today's topic is proactive versus reactive measures. And I think I want to start, guys, with a simple question. And we'll do this before we get into our incident of the month, okay? Let's think about it. What if healthcare organizations managed quality and risk with the same proactive approach as they handle patient care? Let me let that float out there a little bit.
I love that question.
great question,
I have 1,000 answers. So one, ideally, right, there's everything that we do in healthcare is supposed to be proactive. Our goal is to keep patients healthy. All of our quality metrics are on ensuring that you don't come back to see us after something happens. So how are we keeping you healthy outside of the hospital? How do we prevent acute visits? There's PCPs, or the backbone of healthcare. Their job is to identify potential health risks before they become health risks and help manage, right? And although we may struggle with that as a country, that is the idea, that is the ideal state. And that is how we should be doing quality, risk, and compliance in our day-to-day operations. And if we did that, we would save billions, we would save millions of lives. And in general, healthcare would operate with high efficiency, high reliability. And people would have faith in our healthcare system.
Yeah. Timothy, what if?
Oh, that's a loaded question, Gary. I will say, what if we did operate with the same care that we give towards patient care? I think we would see a healthier population, honestly. We would definitely see more funds going back into the healthcare that we can use for other potential areas. We would see reduced fines. We would see happy, healthier patients across the board. And most importantly, I think employees would be felt heard in that aspect. So if we did operate that way, I think it would just make a lot more sense. But for some reason, we haven't gotten to that place to be able to operate in that state.
Think about it, guys. This is why today's topic has me so jazzed up. It's a pet peeve of mine. That, both of you answered, a simple question that points to, well, why aren't we? Right? What's going wrong? So again, before we get into the incident of the month, let's do a couple things. First of all, by definition, to be managing risk, you're supposed to be proactive. Risk, by definition, means you're looking at things that haven't happened yet, but might happen, and trying to get ahead of it and take action on those things so they never happen. By nature of the CMS regulations and so forth, and I'll let you expound on that to our show today, Rob. We're always reacting. We don't take action, whether it's corrective or preventative, until something bad happens. Something bad happened, and then we do something about it. That's not being proactive. As many of our colleagues out there may think so, that is not being proactive. Not from a risk management perspective. It just is not. So let's laying those definitions out there and framing a little bit. Why don't you give us the incident a month, Rob, and then we can build off of that momentum.
So we're
trying to make an argument, right? We're trying to make an argument today.
For an incident of the month, I would actually like to just expand on what you already touched on. CMS, Joint Commission, DNV, there's even NCQA, you name it. Our accrediting and regulatory bodies that tell us how to operate our healthcare facilities, do not direct us. There's to act and design our operations in that definition of risk management that you shared, Gary. There's the definition that you shared is to be proactive, identify beforehand. There's, if you're to go through the conditions of participation, there's for CMS, there's in looking through the QAPI standards. Yes, they do mention you should do an assessment and make sure you know what your risks are. But the real meat of those standards comes in how you are responding, to patient safety events, investigations. There's how you're responding. There's to operational events, how you're responding to, there's complaints, you name it. They are in your response planning and then future mitigation of that already occurred incident. And we call that proactive. And so Joint Commission, same thing, huge emphasis on sentinel events. Even the leadership standards where we're talking about being proactive, there's an emphasis on undesirable patterns that are already identified of negative occurrences. There's things that already occurred. And even the DNV, there's who uses those ISO 9001 base framework principles for quality management, which are phenomenal, by the way. We ourselves are ISO 9001 and very much believe in quality systems. There's, but many audits primarily check for corrective action for non-conformities. There's what did we do for things that already happened. And I could go on and dig into the granularity of these incidents, but what I want to highlight is our main focus from our governing bodies is to react well to things that already happened. And I appreciate the directive to act well when something happened. But the intent of risk management is to prevent it from happening in the first place.
Right, before it ever happens. It's interesting. I remember being on a customer call in my previous life. And I remember meeting somebody who was well entrenched in consulting in the Department of Defense. And we were talking about events occurring, or incidents, as we would call it in healthcare. And he says, well, if you have frequency of an incident, that is no longer a risk. It is an issue. And I found that to be really interesting. I said, well, then what is a risk? Well, risk is all the stuff that hasn't happened yet. It's the stuff we're trying to make sure that they never do. I'm like, well, that's fascinating. So if the way that the Department of Defense, the guys are supposed to keep us safe and fight our wars, look at it as if they've got frequency, that's an issue that needs to be managed at a whole nother level. Shout out to Dan Toll, my good friend. Good to see you out there, Dan.
There's by me.
That is interesting.
Yeah.
I don't know that you can separate it that way, where you can say it's an issue versus a.
I agree. I agree. Yeah.
And I'm curious about their logic behind that. So, there's, to me, healthcare should operate. With really strong assessment skills, right? There's the people that are working in quality, risk, and compliance, they're nurses and doctors. We are trained to assess. We are trained to identify risks to our patient, right? Whether that be in the environment, whether that be through intervention, right? Our quality checks before an intervention happens. And then just through basic data gathering of our patient condition and patient history and profile. Back to your question at the beginning, what if we're operating, in that same perspective in our general operations, we have the skills to do it. We just don't have the governing body's focus or the understanding across the general healthcare industry that proactive is smarter, safer, cheaper. And I do want to emphasize cheaper because healthcare doesn't have a lot of money right now, and it's only going to get worse. So doing things that are less expensive, i.e. stopping risk before it happens because you've identified it, is better for your organization's health, longevity, operating margin.
Rob, you introduced something that really, I don't know, settled on me when you said that our job in healthcare is to respond well. And for some reason in my mind, I think that really is an underlying issue for us. We're built to respond versus built to be proactive. You can look at how we have built the entire healthcare system in organizations. Our main goal is to respond to some type of issue. Patient comes in, has an issue, we respond to it. But when it comes to preventative care or being proactive on the other side, we're so cautious to move in that area, in that space of prevention or proactiveness, because for some reason we think if we're too proactive, then we'll put ourselves out of business. And I don't think that's the case here. I think we really need to understand there is some structure that needs to be built around being proactive to help us enhance the overall care that we are able to provide. There's something weird about that, though. I don't know. When you said we are built to respond well, I don't know. It triggered something in me with my healthcare brain of, yes, we really are built that way.
Well, we in risk management love to look at history, right? We love to look at it because it does provide some predictive models, right? So maybe we have certain types of incidents that seem to happen every other year. And, we'll say, okay, well, I'll put that out and say it's about a 50% probability it can happen this coming year. And there are other things like that too. You can look at hurricanes, right? Depending on where you live, it can be one every 10 years or every year. If I'm in Florida, I have a 99% chance that there's going to be a hurricane event,
True. Yes.
And so, understanding probability and frequency is all part of risk. So I don't agree with this issue versus risk thing either. That sounds like a bureaucratic perspective on how you handle it.
Yeah, I feel like that's more of just a leveling risk, right? Like if we already have mechanisms in place because it's identified and we are working it, monitoring it, assessing it, like, okay, then maybe that's a risk level 1. There's versus something that occurs, acutely is a higher risk, right? But I don't think that you take it out of a risk category.
Like you take one of our customers who they're in the assisted living space, okay? And they had issues with their residents falling, whether it's falling out of bed, whether it's tripping, whether they're attempting to do something on their own they shouldn't be. It doesn't matter. They're falling. The falls are going to continue to happen. The question is, are they going to get hurt when they happen? So there's a lot of measures that need to be put in place to manage this. Now, working with us, we were able to get a little focus on that, to report frequently. And then they started putting in some training around staff to minimize that. They started putting in certain measures that protect the residents if they fell, such as pads on the floor next to the beds. In some cases, were authorized by a doctor. They put up bed rails, bed alarms. They started taking some proactive action, but it's still reacting to the fact that they were falling.
That's true.
Right.
Absolutely.
So,
Right. So in thinking through that, if we could apply really good fall, there's proactive strategies, there's to our operations. Fall proactive strategies are things like maintaining ambulation, maintaining balance. There's maintaining nutrition, maintaining hydration, maintaining overall wellness.
Yep.
Those are really your proactive strategies. And then ensuring that their environment is safe and that they have good Morse fall scales there's in place, and that we have all of the things that you talked about in case falls actually do happen. And I can easily, as three of us could sit here and talk about all of the preventative actions we could take for falls that are truly proactive, maintaining balance, maintaining nutrition, getting them right. Yeah. How are we doing that in our day-to-day operations? There's things like environmental safety, for things like our star ratings, that have a huge impact. On our finances. In our patient satisfaction, which downstream affects their outcome. How are we being proactive and looking at all of those measures and ensuring that we've done a proactive risk assessment to identify risks, gaps
to those things.
Right. Yeah. And then putting in there's quality controls to ensure they don't happen, and that if they do, to your point, Gary, we've already put the mats on the floor.
Yeah.
So we acknowledge that risk is going to happen, but if you're really good about proactive, you're going to quality control it and you're going to risk mitigate it.
Yeah, in risk management, what you would do is you would be identifying to these various sources, like you were describing. You would identify what the probable events would be, and then you put in these measures, and then you monitor with the departments how they're doing with that, just like you would monitor a CAPA, right? Nothing's changed. It's just trying to get it ahead of the curve. That's all.
Absolutely. I was going to mention this question. Yeah.
Yeah. Great question, Kevin.
I love this question. I'll steal the first part of it if you don't mind.
Sure.
So Kevin, in my opinion, it is not incentivized well. So your CMS, there's quality metrics, there's HEDIS metrics, there's pay for performance metrics. There's often touching on the idea of proactive care. But if you really think about where our high dollar amounts and focuses are, it's on things like readmission rates. It is on things like there's antibiotic stewardship. It is on things like, just take those two because I could just keep going on that list. Readmission rates is already a response to something that already happened with that patient.
That's correct.
They were already admitted for something. And we are not incentivizing pop health programs to ensure that patients stay well and using community-based services to stay out of the hospital in general. They've already been admitted. We've already done a poor job of managing that patient's clinical condition. So we are now responding to a gap in care by having them admitted, and now responding again to them being readmitted back to the hospital within that 30-day time frame. So using just that example, I do not think that it is appropriately incentivized through our pay for performance programming. Nor our reimbursement rates.
Oh, and CMS and those guys are completely blind to the proactive side. I mean, their whole notion of it is that you're putting preventative action in place after something happened. So they're not exactly giving you any kind of incentives that you're going to get paid faster or anything through Medicare or Medicaid by doing a proactive risk assessment. There's nothing there, and it really needs to be there.
Yeah, and from their perspective, you go to the mindset of, why do I need to care? If the organization is not going to put an emphasis on proactive care, then why should I individually care? Which is, to me, more of a culture issue of the organization. It should be built into how you maintain everyday workflow for your organization, how you build that into every aspect of each employee's onboarding and things of that nature.
Yeah.
You have to build that understanding, because if it's only going to be monetarily incentivized, and if you don't have the money to be able to pay that, then there's not going to be an emphasis on being proactive for your overall organization out there.
Yeah, leadership should probably do a formal risk assessment once a year that they get out and they get everybody to participate in from the different departments and different perspectives within the organization. And then, you know, maybe quarterly, you know, allow for revisits, allow for people to spot something they didn't see before to get it reported in, so that in the next cycle, quarterly review cycle, it's in there and corrective action, or excuse me, preventative action plans can be put in place, right?
Mm-hmm.
And they should be incentivized to do that. There should be something in an MBO, you know, something that they are going to be rewarded for by good behavior. That's how I feel it should be. But hey, let's move into minute matters. We're kind of getting deep into our meeting here. Keep bringing those questions forward from the audience. We will use those throughout the minute matters. Rob, do we have a slide that we can show the audience that I think would be a pretty good illustration, I think, of where we're coming from? Yeah, there we go. Now, I love this, because what we're doing here is we're saying, okay, if we're being reactive, what should we anticipate? And if we're being proactive, what should we anticipate? And we're matching them up one for one. So for instance, when we're reactive, you're going to have poor patient outcomes because the bad things happened, right?
Yep.
So if we can be proactive, we should anticipate improved patient outcomes. Now, if you're reacting, you're always putting out fires.
Always.
So,
always.
Staff stress, and we hear about burnout. I mean, that's where it's coming from, versus feeling motivated, engaged, and seeing a positive impact. You have an enhanced staff morale. So then reactive, and Rob, we've talked about it over the last year or so since we've been doing this podcast, financial penalties are coming. And many organizations are so surrendered to this, they just go ahead and budget for it.
Mm-hmm.
Where now you can have an effective audit preparedness. You know, audits walk away without fines. And now you're bringing money back into the organization that they can use for new treatments, new surgical wards, whatever they need. And of course, that leads to decreased revenue, which on the proactive side should be increased revenue. And then reputation could be damaged. You have a really serious event that occurs and it gets out there in the media. It's going to affect the hospital's admission rates. It's going to affect their overall reputation to the community versus trying to enhance that. So we try to get it simple and get it down to 5 items. But I think these are very powerful arguments of why you want to go proactive. It's a cultural thing, as Timothy was talking about.
Mm-hmm. I agree.
Absolutely.
It is about culture. I think it's about understanding. That's one of our goals here, right? Is to help bring awareness to the fact that, okay, just because you read it in CMS standard, that's what we're supposed to be doing. That's not all you're supposed to be doing. Right. Right. Like that's the bare minimum. There's what we should be doing is doing right by our organization, which then trickles down to doing right by our patients.
Yeah. Okay. 5 minutes, 5 questions to wrap this up. And then Rob, you get the last word today.
And 5 minutes, 5 questions. So we actually have one additional in the audience.
Great question too.
My good buddy Dan Toll. I haven't spoken to him in a long time.
And so how do we convince healthcare top management to take a proactive and enterprise-wide risk management approach? There's, in Bob's words, better, safer, and cheaper. There's agreed. There's my opinion is your return on investment assessments, right? Where you're showing if we would have identified these risks ahead of time, here's what we would have saved, because this is what they cost us. So having a really good cost to poor quality assessment, there's at a minimum annually where there's assigned a dollar value to how much time wasted, how much time paid back in penalty and fines and attorneys, there's or payouts for malpractice, you name it. There's collecting all of that data and saying, here's your return on investment. That C-suite tends to respond to what's going to keep those doors open. I don't want to say it's just about the money, but they really do want to make sure that we have an operating margin to keep business afloat. So I think it's one, convincing them of that. Unfortunately, there are not a lot of programs out there that aid in that. And out of the 12 years that I've been doing this directly, in 19 years, I've been doing this as a nurse and indirectly in quality and risk. I have met maybe 3 or 4, and it's because they've been on our team that really understand cost of poor quality. There's understand how to assign dollar values to risk. It's just not a skill that there's healthcare teaches. It's risk and quality people.
Yeah, absolutely. Rob, if I can summarize everything you said and to really hit on Dan's question, it's dollars and cents. You have to speak money when you're talking to healthcare executives. What's going to move the needle? What's going to reduce the overall cost? Rob hit on a number of things that will help to kind of build that argument for you as you're working with those executives. But really, it's around dollars and cents. What is costing you the most for your organization? And I could probably tie it to some situation that either needs to have a proactive approach or reduce the overall hands of how reactive we are to the overall approach as well. So if you can speak dollars and cents to them, if you can find those the statistics that we shared here on the show about, a healthcare organization that's 150 bed hospital, we're looking at somewhere around, 14 million a year that we're spending on quality issues that could be definitely corrected and moved around. If you can have those dollars and cents available, you're going to get there. You're going to see their ears perk up. You're going to hear them listening and wanting to know what your overall plan is going to be to reduce it.
Yeah, when you're talking to top management, trying to get their support to get behind an initiative like this, you got to speak their language, right?
Correct.
And the language of the C-suite is always dollars and cents, right? They're constantly managing it, trying to figure it out. Rob, you're right. You got to have a baseline, understand the cost of poor quality. You got to have it, right? There's no way around that. Second, when you're doing your assessments, be able to look at how you're able to change those numbers and bring them down. Now, we know from studies we've looked at, that number could be 15% of revenue.
At least, yeah, which is insane.
That is correct.
Now that may be different hospital to hospital, but you would think CFOs, top CFOs in any of these organizations is looking behind it or under the curtain or, under the kimono of what's behind that cost of poor quality and how can I begin to address it. Going proactive is one of the ways to do that. Let's stop taking it on the chin and let's get ahead of it.
And Daniel and anybody else on the call, there's we at Aperitisoft Healthcare have a calculator that if you reach out to us, we'll be happy to help you establish at least a high-level baseline for you to take back to your leadership and have that conversation. Our main goal is to help spread these messages and help get everybody on a proactive floor, right? So let us know if you want assistance. There's inputting your numbers in. And we'll set up a brief call with you.
Okay, we got one more question and then last word, and then we need to wrap it up for today. We are already burned through our half hour that fast. So,
and I actually think that we answered all of the participants' questions. There's either in conversation or directly by bringing them onto the screen.
That is correct. I put a question in the chat, and feel free to respond, even if it's after the overall podcast. But I just want to know what the biggest challenges in shifting from reactive to proactive management is in your organization. So feel free to answer that in the chat whenever you have a chance. And we love to discuss it, even if it's for the after show coming up.
Yeah,
I love that.
Okay, Rob, give us a last word then, bud.
So my last word is I'm trying to focus it down to just some words instead of a whole stream of consciousness. Proactive healthcare is not just about our patients. As far as treating them directly, it's about the infrastructure that supports the patients that will help keep them well. So we need to shift our thinking from, hey, I'm meeting the minimum regulatory and accrediting standards by reacting to things appropriately and preventing them from happening again, which is not proactive. That is still reactive. there's operations, and change our mindset. There's to many other successful industries, there's where they have figured out how to identify risks to their organization and their business. Everything that we miss in running our business has a negative effect on our patients. And we need to start being proactive if we want our patients to do better, if we want our operating margin to do better.
Great. Good summary.
That's awesome.
Very good. Well, listen, everybody, thank you so much for joining us for our live broadcast of Healthcare Quality and Risk Matters. Now, if you want some more, you can join us in about 10 minutes for our live after show. That'll be located over on YouTube. Do you guys have a link that we can supply folks, maybe in the chat?
I just did. Mm-hmm.
Okay, outstanding. Please keep putting in your comments, like our show out there, share it with others, go to the Aperitisoft page for on LinkedIn and ask for us to invite you to our newsletter. Follow us if you can, please. Your support always makes this possible and helps us to keep bringing some great content forward for you all. So any other last comments, guys, before we call it quits?
No, thank you everybody so much for joining. The participation was wonderful and phenomenal questions from everybody.
Absolutely. See you at the after show.
Right, see you at the after show.